Hello, everyone, and welcome to our conference. My name is Mouaz Al-Mallah, and I will be talking today to you about cardiovascular PET, the basic principles and current applications. So let's start with the anatomy of the PET scan. This is the machine that we will be using and referring to during the lecture today. And Dr. Mamarian, a few weeks by perfusion imaging that have been about how PET is different than SPECT and where are the things that are that differentiate PET from the SPECT myocardial perfusion imaging. Please also during the lecture send questions, and for our colleagues that are the questions via Zoom, and hopefully we'll be able to answer. SPECT imaging relies on two heads. They are usually around the patient. We inject the patient with a radiotracer and we take pictures. Now, usually the detectors are around the patient, but only half the way. So the patient will have two detectors that are 90 degrees apart or so, and they are like rotate around the patient. So these detectors rotate around the patient. However, in PET imaging, and this is the machine that we have in our lab and our research institute, so it is a PET CT. So in the front we have a PET, the CT machine. On the back we have the PET machine, and it is a hybrid system that allows us to acquire these images. And behind these covers, this is one vendor how they have the PET CT. This is another vendor, and the same concept, the table, you have the gantry, the PET system. Now, this is if we take the covers, this is how the machine looks like from inside. So it has a PET and a CT. So in the front, you have the X-ray tube and you have the detector, similar to what Dr. Chang described a few weeks ago, where you have an X-ray tube that will shoot some X-ray beams, and then it will be detected after it passes through the object or after it passes through the patient. Now, in the PET scan, in comparison to SPECT imaging, the PET scan, we have a circular ring of detectors that are completely around the patient, and we call it a ring, in contrast to what we see with the SPECT imaging, where we are only covering the front of the patient. Now we are here covering primarily the entire circle of the patient. And this is very important because it has a lot of important implications for the detection of the photons that we get and during the imaging procedure, as we will describe a little bit later. So the first difference between SPECT and PET, while in SPECT we have the detectors only have a full circle of detectors around the patient. Now, each one of these, we call it a detector unit. So here you see each yellow box is a detector unit, and I'm going to take you even deeper, and we're going to dig deeper and see what's inside that. So that unit is composed of few things. It has initially the detector itself. So in PET, we use different detectors. The most commonly used are the LSO, or the lutetium based. So we will have the detector, or some older system used to have the BGO kind of detectors. In contrast, in SPECT, we use sodium, and we will have followed by the electronics, and then we put it all in one detector. So again, zooming in, we get the whole box of detectors. We make it a square, and then the whole unit is attached to a photomultiplier tube, and then behind it is the electronics. So when I go back and look at this here, every unit will have a detector. Behind it, it will have a photomultiplier tube, and then behind it, there are the electronics that will take the light. So one of these, again, is the same thing. Block of detectors, photomultiplier tube, and then the electronics that will take are the crystals. As I mentioned, in SPECT, we use sodium iodide. In PET, the most commonly used right now are the lutetium base, which is the LSO, and the other vendors use LYSO, which is like 90% of it is about 90% of it is LSO, and then older systems used to use BGO. So what happens? You got a gamma photon that's being detected and being that leaves the patient because we inject the radio tracer and it's come in. It will hit the photomultiplier. It will hit the detector. The detector will release a light photon, and then it will go and get amplified in the photomultiplier tube, and then it will take it to the electronic. And if we move forward here, so this is what happens inside the photomultiplier tube. You get one light beam that will just get multiplied. So from one stop to another stop inside the photomultiplier tube, this light beam is getting amplified, and then it will be taken out through the electronics to the processing units of the machine. So this is how it looks like. Now we have newer detectors where the photomultiplier tubes are digital. So these allow for higher sensitivity nowadays. Now there are few differences between older systems and newer systems, which is the 2D versus the 3D systems. So the 2D systems where we have some septae, so we will only detect photons that will come and pass through the septae. The detectors, there will be lead septae that are in front. So the 2D systems are not very efficient. So you have to inject a lot of radio tracer, and anything that's scattered or not moving in that very straight line will not reach the detector and get absorbed before. While in 3D, we will not have these septae. So the 3D of these systems, so if you want to buy a new system, you're going to only be able to buy a 3D system. They have higher sensitivity. You can use lower radio tracer with them. You can have lower radiation exposure, and potentially may have some cost saving because your radio tracer is going to cost less. However, there are some challenges where the effective sensitivity is lower, but what I'm only through systems, but you may be detecting some additional randoms or scatter. There will be more processing time, and the files are are bigger in size, and there will be higher background noise. But now we have electronics and electronic solutions that effectively deal with these, and we are able to get adequate imaging with 3D systems, and that's why the technology have mostly moved to PET positions. So again, I mentioned this is how what each unit will look like. Now it is in the newer systems, everything is digital. So the photomultiplier tube is going to be this PMIT, which is more of uh, the PMT will be digital, so it's not going to be that big, but it is way more sensitive. And now we have even gone even much lower doses with the digital system. So just to put things in perspective, if you are using a 2D system, you need to inject about 50 to 60 millicuries of rubidium to be able to get a myocardial perfusion image. Moving down to a 3D system, you can lower that dose to about 25 to 30, depending on the weight of the patient. Now, using this digital system, we are able to routinely do these studies with from 2D all the way up to the PMIT. So PET is already low radiation dose procedure, but now we have lowered it down significantly, and we can use our generator for longer time compared, because we are utilizing it shorter time as long as within that 7 week of non-expiry. So what happens when we acquire the image of the patient? So we're going to talk about the radiotracers a little bit later, but what happens is that we inject a different radiotracer compared to SPECT. So in SPECT, Dr. Mamarian in his lecture talked about different radiotracers like System MEBI or technetium tetraphosphamide or thallium. Here we are using higher energy. We are using radiotracers that will do positron annihilation. So initially we'll have a positron. Depending on the energy of the positron, it moves up a little bit, and then it will cause the electron positron annihilation. So what will happen is that the positron will annihilate to give 2 electrons. So these 2 electrons are going to be about, and then the gamma rays will be about 180 degrees apart. So they will go in different directions. One will go up, the other will go down. And that's why we need a ring of detectors, because when the positron annihilate, the gamma rays will be going differently, one up and one down. And that's why they will be 180 degrees apart. So now one photon is going to hit here, the other photon is going to hit here, and this is what we call a true event. Now, how does it happen? So you have the positron, you have the 511 keV, the gamma rays, they will be going out at 180 degrees, they will hit the detector, the photomultiplier tube, and then they will go to the system. The system will look at these, and then it will look at the other signal that's coming from the detector that is 180 degrees apart. And if the time between the two is less than 4.06 nanoseconds, so we're talking here nanoseconds, then we will call it an event, and it will be recorded as true positron annihilation, and it will be recorded at this point that there was some positron. Now, it's easy because we have different situations. Sometimes there will be another positron will go this way, and then if that happens, then there will be the positrons are going to look as if they're coming from here because they happen to be across a 180 line, but the reality is that sophisticated scatter correction methods that can deal with that based on the timing, but also based on the energy that you might get through these. And sometimes it's just a random thing. One positron will come hit here, and another positron will hit at this point. Sorry, not positron, gamma ray. And then on another one, another gamma ray will hit here. So it might appear as if there is a line of coincidence here, and this is just random. So when you have a lot of radioactivity, and on our, like for example, digital PET, we have initially a lot of randoms, a lot of scatter, but as the radio tracers start to decay, we start to get more truths, and the system is able to differentiate now between the randoms, their effect on image away, and that's why we try to keep only the true coincidences, and this is where we are able to generate a good image there. And one of the ways that the system used to look for that is to primarily look at the energy window. So the peak energy window for our photons are going to be around 511 keV. And that's another differentiator from SPECT imaging, because at SPECT imaging, if you're using technetium, you're imaging at 140 keV. And if you are using thallium, you will be imaging at 70 keV. So here the energy is much more. And for example, CT energy is still about 122 kVp. The peak will be around, depends on what energy you're using. It's ranging between 70 to 140. Now here we're using 511 kV, and the scatter is going to be on the lower end. That's why if you tighten your energy and you have a good sensitive system, you are able to tighten your energy window and accept only those that are close to the 511 keV, and that will still be able to and have enough counts to generate an image. However, there are certain things that are very important in PET. One which is very important is that we also would like always to do attenuation correction in PET compared to SPECT, because the attenuation correction, because these gamma rays are going through different tissues, so even in the best situation, there will be some attenuation to them. And we would like to know through what milieu they're passing through before reaching the detector to take that into account. So then one additional message I want to leave with you in terms of the differences between SPECT and PET is that, for example, our fellows know that attenuation correction in SPECT is a luxury. I mean, if you have it, it's great, but you can read the study most often without attenuation correction. But if you have it, that will give you the best kind of situation. Now in PET, if I don't have attenuation correction, I cannot read a perfusion study. So it is a must to get attenuation correction. Now there are multiple ways to do attenuation correction. Older systems used to have transmission sources that are in front of the machine, and they will be rotating around, and they will create what we call a mu map or attenuation map. And this way you can estimate what kind of milieu these photons are passing through before reaching the before reaching the detector. In contrast, this method is not the most efficient. There are many drawbacks for that. And that's why it's now only available in older systems that are refurbished. So if you go to a company and you want to buy a new system, but you want it with transmission source, it may be very difficult to find one in the market. Now everybody have moved to CT for attenuation correction because it is very fast. It takes only a few seconds. It's low energy. So we're not acquiring a diagnostic CT. We're acquiring a very low dose CT. So it's the purpose of this CT is primarily to tell me where is the lung, where is the bone, where is the soft tissue, so we can calculate what we call a mu map, which is for the assessment of the different tissues that the photons are going to be passing through. So it is we use a low energy kind of situation to allow us to do attenuation correction, and I'll show you some examples later on these. Now there's a lot of work on PET MR systems to use MRI to do attenuation correction, but this is, I think, still at this point research, at least for cardiac work, and not ready for prime time. So this is a CT that you will have. This is kind of the mu map quality. So it will tell you where's the lung, how many centimeters of soft tissue that you have, how many centimeters of bone, and then you will assume that the heart is where it is, that the two images are in the same position, and then you take the image quality that you see here, will be attenuation corrected, which will allow you to look at these in details. Now, when you do attenuation correction, you're always prone to some problems. And here's one case where you see the excellent image quality of rubidium PET scan in a patient. And you can look at a patient and you can see that at rest, which is the second row, the fourth row, the sixth and the eighth row here, you can see that there is no perfusion defect. Looks great. Now, looking at the perfusion defect in the anterior anterolateral wall, which is mostly in the apical, mid, and even basal segments. So most of the anterolateral wall has a perfusion defect. When I go ahead and look at the fusion images, which is where I fuse my CT and lung tissues, CT and cardiac images, the PET images, then I will see that the heart is not where it should be. So I'm correcting the heart for the attenuation coefficient of the lung, assuming that the heart is sitting over the lung, which is not very true. The heart doesn't sit over the lung. They are like the heart is where it should be. So, but the patient moved in between the acquisitions of the two images. Thus, when I fuse them, these images are coming like laid on top of each other. And this is why I know that this is inducing a defect, because the attenuation correction, instead of helping me here, resulted in an artifact. So how do we fix that? Now also all vendors have the ability, give you the ability to go ahead and move around and just move these images and reprocess it. And this is what we did here. So we moved the heart to where it should be. It's not overlaying the lung. And now we see a nice normal image. So it is very important to keep this in mind while doing cardiac PET or any other hybrid imaging that will take into account this fusion between the perfusion imaging and the emission or the CT images. All right, so let's take a quick pause here. I've kind of mentioned a lot of the differences between SPECT and PET, but I'm gonna just try to summarize them here. The main one is that we're imaging with 511 keV photons compared to 140 with SPECT. We use here what we call a list mode acquisition, so we can get myocardial blood flow data. Here we use the bind mode acquisition, as Dr. Marian covered, because I mentioned that our systems are way more sensitive, so we get way more counts compared to SPECT, as the sensitivity of the detector is higher, and it is a faster acquisition, and then the spatial resolution is much better compared to SPECT imaging. Now, obviously, the spatial resolution detect on multiple factors, including the radio tracer we're using. And this is a good segue to the radio tracers or radiopharmaceuticals that we use. So there are major differences between the radio tracers we use in SPECT and PET, and this is a very important slide, so I would like to spend a little bit, few minutes on it, where on SPECT we can generate them with we get the radio tracers with generator. Here you can do some with generator like rubidium, some of them will require a cyclotron like ammonia or FDG. The energy, we kind of covered it between 70 to 140. We're using much higher one here. The resolution, Dr. Mammarian covered this very well. It's 20 millimeter for the FWHM, and it is 10 millimeters for the PET, so it's more sensitive here. So we have attenuation correction, so we get less attenuation, but despite that, we're going to acquire also with attenuation correction. The half-lives are shorter with PET, so that's why even though we're imaging at a higher keV, but we are able to achieve lower radiation dose because the radio tracer is going to be inside the body of the patient for very few seconds or sometimes maximum minutes. And the study duration lasts only for example, a perfusion study is about 30 minutes, but because of the short half-life of the radio tracer, we're not going to be able to do exercise more often. So it's mostly pharmaceutical. However, when we do use the longer half-life radio tracers like ammonia, and later on, if we use an F18-based radio tracer, theoretically, we might be able to get exercise information. So if we now zoom in onto the radio tracers that are approved for perfusion, the ones that are approved for perfusion in the US are Rubidium 82 and N13 ammonia. O15 water is only approved in Europe and used in few centers, and FTG is primarily used for metabolic imaging. The half-life of rubidium is about 76 seconds, ammonia is about 10 minutes, FTG is almost 2 hours. And just to keep things in perspective, usually to get the radio tracer out of the complete decay, you need almost 5 half-lives. So if the half-life, for example, of rubidium is 76 seconds, then you need 5 times 76, which is about up to closer to 380 milliseconds. So by almost 7 minutes, when the patient leaves the lab, they have no radiation. Now ammonia is about 10 minutes, so it is 5 half-lives, which is 50 minutes. FTG is about 2 hours, so the patient will have FTG on board for about up to almost 10 hours. Now, the positron range we'll talk about a little bit later, but I want to focus on the image quality. I would say image quality is best related to the positron range, and it is best with excellent with N13 ammonia and FTG. But now with the newer radio tracer, with the newer systems where we are able to differentiate the scatters, we are able to reconstruct good images with rubidium 82. So the extraction of these radio tracers, and I put the technetium, the SPECT radio tracers here too. So the extraction is linear for O15 water, and this is a board question for both cardiology and for nuclear cardiology. They love this question: which one is linear? Because if you use, and that's why it is very difficult to get an image of that, because it's O15 water and it's just gonna diffusely get in and get out of the cell. while N13 ammonia and rubidium 82, they kind of roll off at higher level of higher levels, but the extraction, so they made the myocardial radiotracer uptake may not be in a linear relation one-to-one, but there are to account and try to adjust for it, and that's why at this time it's clinically feasible to achieve good quality myocardial perfusion imaging with this, because it will take into account the myocardial tracer uptake and retention. So rubidium is probably the worst in terms of tracer uptake compared to the other radio tracers, the PET radio tracers, and Sestamibi and tetraphosphine are probably the worst here. Now, if another very important concept that we need to kind of cover is the issue of annihilation and positron range. And this is very important because it will define why some images look crisper than others. So when we inject rubidium, for example, in the patient, rubidium has very high energy. It's among the highest energy compared to the other radio tracers. So what happens is that rubidium is in, it will stay inside, it's a potassium analog, so it will get to that myocardial cell inside that potassium, and then it will annihilate, and it will be moving a little bit because it's higher energy, it will move before it annihilate and give the two electrons. So the annihilation is going to happen with some distance between where the positron is, because the positron is here, it kind of moved, the rubidium is here, the positron is going to move a little bit to here because of the high energy, and then it will annihilate and give the two gamma rays. So while on 80 degrees line, we're going to say that the positron could have originated from here. In reality, the positron is sitting at this point, and this positron range will give this kind of image blurriness because we're taking it into account when we are reconstructing our image. So the positron might be here, but we will be saying on our reconstruction that it came at this point. So this positron range varies between radio tracers based on their energy. And that's why if we go ahead and take different radio tracers, and for example, and the positron range also vary according to the milieu that they are in. So the positron range of O15 water is about 4 millimeter. For ammonia, it's better, 2.53. For rubidium, it's 8.6, and for F18, it is 1.03. And that's why F18 kind of images look much, much crisper because they have less ambiguity from the positron range or blurriness from the positron range. I'll show you some examples of some images. So this is a nice rubidium image. It's a SPECT image because the myocardium look a little bit thicker than usual, and it kind of gives us the impression that we have like more of a relatively a little bit blurred. This is now going to ammonia, and you can see that the images look a little bit more crisper here. And you also with ammonia, you see the inferolateral defect, which is normal with ammonia. Now keep these two images in mind, and now I'm gonna show you an F18 image. Now the F18 image, keep it in mind that it has the best positron range. So the best positron range, the shortest positron range, and now you can even see the details of the myocardium. You can see the anterolateral papillary muscle. The images have sharper edges, and these are kind of zoomed images. So you can even see the RV, and like here it's not very clear in terms of ambiguity, but here it's very clear where the RV free wall is. So to put things in perspective, this is the impact. What the differences between these two images is primarily the impact of the positron range. And that's why if you're going to move from one tracer to another, you have to train your eye to look at different tracers and differentiate what is different between the images just because you are using a different radio tracer. So let's radio tracers, and we will be covering different ones here. So we have N13 ammonia, rubidium, and as I said, O15 water doesn't usually give you a nice image. It's primarily to measure flow and O15 water, it's the ideal flow tracer. Its first pass extraction is almost 100%, and it is the gold standard for comparing other tracers. So everybody wants to compare their flow data to O15 water. The half-life is about 2 minutes, so decays quickly, and it has a low count rate because it's kind of spread all over. Now, ammonia has a cyclotron produced. Its half-life is almost 10 minutes. It depends on the system you use, but usually for older systems, it's about 20 to 40 millicuries. And the newer systems, people are able to get nice images with much lower doses, even down to 10 or even 5 millicuries. Now, it can be combined with exercise, although there are some additional staph exposure issues. So it is not routinely used with that, but it can be done, it can be used with exercise. Now, if you have an old system and you injected the full 20 to 40 millicuries at rest, you have to wait before stressing the patient because now you need to inject another dose to be able to acquire the stress image. So one of the main limitations with ammonia is that it always needed a cyclotron. So if you don't have a cyclotron within your vicinity, you're not going to be able to do ammonia. Now there is a company that has a mini cyclotron. The company is called IonTex. They will come and put this mini cyclotron on your site, and then they will give you ammonia when you need it. So technically you don't need to have to buy a full cyclotron, but rather have a mini cyclotron that can be put and just give you ammonia there, and you will be able to do the cases that you need. Now, rubidium is probably the most commonly used for perfusion because it's generator based. So you get a generator every 42 days. The half-life is 75 seconds. And again, it depends on what type of machine you have. You inject the doses accordingly, and you inject it over for 30 seconds. And now we have two vendors who have rubidium 82 generators. And this vendor, Braco, actually has a newer injection system that, in addition to this is coming from GDI and Jubilant, and both of them are able to give you rubidium, and you can perform your study. The ease of using rubidium is that you have rubidium in your site. So if you want to add a patient late hours, long phone will be sitting next to the machine, and then you will inject from the injector directly to the patient. So technically once you get your generator, you're all set for the duration of the generator. So again, I showed you this image before. This is the kind of images you get. And this is why there have been some work trying to get some F18 based tracers. So I have not talked about it, but there is one which is currently being tested. It's called Flurperidas. and now it is undergoing a phase 3 trial. And this phase 3 trial is comparing SPECT to flurpiridaz PET, and this trial hopefully will be completed soon. And here are some images from previous studies done with this radiotracer. First of all, you can see how thin the images are compared to other radiotracers. And you can see even the more details of the myocardium. And what you see here is that there is a perfusion defect that was not seen at all on SPECT, but now we can clearly detect it on PET. So clearly the higher sensitivity of PET compared to SPECT. This is a trial comparing flurpiridaz PET to technetium SPECT. And this is another case where now the images look good, but you can see an inferior defect, and there is really nothing here. On SPECT, there is an inferior defect, and on flurpiridaz PET, there is no defect that you can see here. So in short, what are the PET applications that we do? We talked already about PET perfusion. I've shown you some examples through. So who are the patients that would potentially benefit from PET? So if you have already a patient who had a prior suboptimal or equivocal stress, there are technical limitations with SPECT, then these are patients that you would like to send them to PET. If they have a BMI of 35 to 40 kilogram per meter square, some insurance accept 35. Some insurances are very strict about the 40 number. And these are the patients that would benefit from PET myocardial perfusion imaging. Workup of new onset heart failure, because these patients will have perfusion defects, wall motion, and incorporating more data and more accurate data would be very helpful. Among patients who had cardiac transplant, looking for transplant vasculopathy, because the decision is primarily made based on myocardial blood flow assessment. If you want to do young patients by nuclear for different reasons, then this is the test of choice because the radiation exposure is very low and lower than all the other additional available modalities. And then calcium score of more than 1,000, or I might even argue that the calcium score more than 400, PET would be a better test, especially to avoid balance ischemia. You can see that the image quality improves, especially in obese patients. This is the case from the literature, where you see a very obese patient, the kind of image quality we may get with SPECT, and the improvement with rubidium PET. And this is also a case that we can look here, and you can see this is a patient who has a large perfusion defect. It looks a little bigger on stress, which is on the top row. So this is a perfusion defect. This should be a full donut if it was a normal study. Like what you see here, this is a full donut, so it's a normal study here. You don't see the full circle, and there is decreased counts in the inferior inferolateral wall, and it's a little bit more on stress compared to rest, and which makes somebody think this is a fixed defect, and I would like, probably some people will call it a scar in there. But the beauty of PET is that you can do also a lot of viability imaging, and we will have later on a full hour dedicated to viability imaging in this series of lectures. And if you do viability imaging for this patient, you can clearly see that there is almost normal uptake in that area. So this is what we call perfusion metabolism mismatch. And this is a viable segment despite the dense perfusion defect. And this is a patient who has hibernating myocardium in the inferior inferolateral wall and would benefit from revascularization. And we will discuss this later on in our viability lecture later in this series. And if I zoom on these images, now you can clearly see that there's a dense perfusion defect at stress and at rest, which like looks minimally reversible. But now you can see almost normal uptake with in the inferior inferolateral wall, just minimal decrease in count. And this is a clearly viable segment that would the patient would benefit from revascularizing the circ or RCA. In terms of accuracy of perfusion, this is data from the Pacific trial, and looking just at flow, you can see that PET had the highest overall accuracy, either per patient or per vessel analysis. And you can see it was like overall 80% by the diagnostic accuracy by per vessel. And if you take just flow, and we're not talking here the overall symptoms, this is because this was done with O15 water, so we only have PET myocardial blood flow, and it is 86% with PET. And because of all these characteristics I've shown you, this is a paper just got published 2 days ago. You can clearly see that there is an increased interest in cardiac PET and other imaging modalities clearly, but these imaging modalities are growing. But the biggest growth is actually in cardiac PET, in part due to the changes in the demographics of the patient, but also due to the additional characteristics that you get from a PET scan. If we move on also to other applications that we do, this is a patient that we discussed yesterday in details in our professor round, but this is a patient who has an inflammatory cardiomyopathy, so we can look at the inflammation, and there's clearly an FDG uptake in the distal anterior wall, and the apex, and this is a patient with inflammatory cardiomyopathy, as we discussed. But we don't only look at inflammation in the heart, but we also look at it outside the heart, and this is a patient who has, in addition to inflammation in the myocardium, there is inflammation in the aorta, and this is a patient with aortitis, as you see in here, as in this case with images superimposed on the CT contrast. We can also look for additional complications using FDG PET from endocarditis. This is a patient with abscess, as you see on CT. Fusing the CT with contrast with PET images, we can clearly localize this abscess, but also identify another early abscess zone here at 12 o'clock in this image, which was not very well seen, but you can clearly see that there's significant FDG uptake in this segment there. We also not only look at prosthetic valves, but we also look at LVAD, and this is where PET adds significant incremental value over other imaging modalities, which have several limitations in assessing LVAD infections. And this is a patient, for example, who have an infection in the outflow cannula from the literature, but this is another patient from our lab, and you can clearly see the outflow cannula is very, it has very intense FDG uptake, and there is significant inflammation and due to infection in this patient. So these are some of the procedures that we do with cardiac PET. Primarily, our main working procedure is perfusion and blood flow quantification, but in our lab, about 20+% of our procedures will utilize FDG, looking either at viability imaging, inflammatory imaging, infections, and we even extend it to vascular graft infections, and we have collaboration with our vascular surgeons who look for these routinely using cardiovascular PET. So with this, I'm going to stop, and hopefully in the future we will have multiple lectures covering the role of PET in each of these modalities, and we will cover it in details. And at this time, I'm going to ask you if you have any questions please text them and we will be happy to answer them. So I see one question that says, can you do a brief discussion on congestive heart failure? Yes, so we have multiple uh, we have on the clinical applications, we have a full lecture that's coming out to talk about the role of PET in viability imaging and also in the role in inflammatory cardiomyopathy. And we tackle it more from a multi-modality approach. So my colleagues will cover the role of echo and MRI and CT in these. I will also be talking later on about the role of infective endocarditis, but this introductory lecture was more focused on the procedures that we do and then how we can tailor it later on to the needs of the patient. And we will be covering them through this series in more details. And I will ask our colleagues also who are on Zoom if you can text your questions or call them out, unmute, and ask your question. I'll be happy to answer them. All right. Any other questions from the group? If not, I would like to thank you for your attention, and I look forward to the additional lectures later on this series on multimodality imaging. Thanks for joining us.